Buenas noches. Es un privilegio el día de hoy tener entre nosotros a Georg Schett. El doctor Schett es profesor, director de la Clínica Médica de Inmunología y Reumatología de la Universidad de Erlangen-Nuremberg en Alemania. Desde su primera publicación en el año 2002, donde hablaba de la interacción entre osteoclastos, osteoprotegerina y factor de necrosis tumoral, el doctor Schett ha tocado y rebasado varias fronteras del conocimiento. Las más evidentes son las relacionadas a espondilitis anquilosante, lupus eritematoso generalizado, lo que él llama en un artículo osteoinmunología y finalmente en la inmunopatogenia. En diciembre del año pasado, con el doctor McInnes, en New England Journal of Medicine, publicaban un artículo de inmunopatogenia en artritis reumatoide. El día de hoy nos hablará sobre nuevas fronteras en el tratamiento de la artritis reumatoide. Doctor Schett, bienvenido a México.
So, good evening, ladies and gentlemen. Thank you for the introduction. And unfortunately, I have to switch to English because my Spanish is horrible, and you will not appreciate my lecture when I speak it in Spanish. So I will present it in English, and I was told to speak about management of rheumatoid arthritis, which is, of course, as rheumatologists, it's not only medical management, but it's also physical therapy. But I want to concentrate on the medical management, drug therapy of rheumatoid arthritis, and show you some ideas about the history of drug therapy in rheumatoid arthritis, the current challenges, and also the future development in the treatment of rheumatoid arthritis. So this picture I have shown already in the morning session at the National Institute of Rehabilitation before my extensive lunch, including wine, and so I'm hope that I can present it as good as in the morning. So when we treat rheumatoid arthritis, we have to target inflammation. We have to target this central part of the problem, which is the synovitis. So the better we treat the synovitis, which is the source of inflammation in rheumatoid arthritis, and the better we treat the destruction of the joints linked to synovitis, the better we do for the patient. And we also do better than to retard the systemic consequences of the disease, which are many. One of them is atherosclerosis, like you see here, which results in myocardial infarction and stroke. The other one is effects of inflammation on the brain, which is linked to a change in serotonin metabolism in the brain and increased depression and learning deficiencies. We also want to basically change the acute phase response. We measure acute phase parameters, so we measure what the liver is doing and what the liver is told by the inflammatory tissue when we measure the C-reactive protein, when we measure the blood sedimentation rate, and all the other markers of inflammation. And we, of course, want to protect the bone and the muscle, because when you have long-standing inflammation, you result in osteoporosis and you result in sarcopenia. You get fractures and you get frail and old, and you don't want that because everybody wants to be young. So, what is the aim of the treatment for rheumatoid arthritis? It is both targeting the inflammation, and I apologize for this, it should mean targeting the destruction. So rheumatoid is always a process which is has a very strong interaction between an inflammatory tissue, that's a human joint. You see this huge inflammatory infiltrate in patients with rheumatoid arthritis, and on the other hand, the destructive part, it's the cartilage and bone destruction we want to target. So we don't use only non-steroidal anti-inflammatory drugs in rheumatoid arthritis because non-steroidal anti-inflammatory drugs, when you take an ibuprofen, you will probably a little bit affect this, but not very well. And you will not target the destructive part at all. So we have designed medications which are disease modifying. And disease modifying means that they suppress inflammation in the long run, number one, and that they also protect cartilage and bone from destruction, and at the end inhibit the disability in patients with rheumatoid arthritis. So we started a long way, and initially what we did is we used herbal medicine, and herbal medicine to treat inflammation was based on the fact that some herbs, like for instance the willow tree. The willow tree is one of the sources of salicylates, and it was Johann Andreas Bucher in the early 19th century who isolated salicin from the willow tree. And when you look at the Australian Society of Rheumatology, they have the willow tree as their logo, and it's because this was used as a herbal medicine to treat different kinds of arthritis, like rheumatoid arthritis, before we developed chemical compounds who did basically the same job. And the first drug which was used basically to treat rheumatoid arthritis was, which was a chemical drug which was synthesized, was aspirin. And aspirin, many of you know, was synthesized in the late 19th century and was basically a similar product like in the spirea plant. So it was also kind of a salicylate, and it was identified which structure it has, and then it was basically produced by a chemical process, and this led to aspirin. And the company of Bayer was the first bringing this to the market, and when you look what they also brought to the market is heroin. So heroin was also a very good medication at these times, but of course lost some importance over the time. But aspirin is still a drug we use, and we are very happy that we have it for headaches and also for treating, preventing myocardial infarction. So what happened next? And you know that salicylates like aspirin were not very well in disease protection. So when you look at Renoir's hands, he used a lot of aspirin to treat the disease because no other medication was available at this time. When you look at his hands, you will see that Renoir was seriously crippled by the disease, and that tells you that the role of non-steroidal anti-inflammatory drugs in rheumatoid arthritis is very, very small, in contrast to ankylosing spondylitis and other forms of spondyloarthritis. So the next step was in fact again a step which is going back to nature, because ACTH was isolated from the pituitary glands of animals, and was then purified from the pituitary glands and was then injected into patients in the 40s. And when you read, and I'm sure that you have read already this short statement how this young patient with rheumatoid arthritis did, you can imagine what a breakthrough it was in anti-inflammatory therapy when ACTH was introduced. And ACTH is nothing else than a glucocorticoid release substance, and it was the initiation of glucocorticoid therapy. We don't use ACTH now anymore so much, but we use glucocorticoids, and you can imagine what kind of breakthrough it was to treat inflammation much better than just with aspirin. And you will appreciate that we give 20 mg of glucocorticoids to a patient with rheumatoid arthritis. Usually the patient is extremely happy. So it's one of the most potent anti-inflammatory drugs which have been developed. And the problem is only the side effects. And one of the first patients which were exposed to ACTH were patients with rheumatoid arthritis. And then many of them died, in fact, of gastrointestinal bleeding and other complications from high-dose glucocorticoid therapy. And now we are much more careful using glucocorticoids in our patients. So what happened then was a strong chemical revolution in the 20th century. So the 20th century was basically characterized by the development of small molecular drugs, which were improving the management of many of the frequent diseases, like if you think hypertension, if you think hypercholesterolemia, if you think about of anticoagulation. All these drugs are small drugs, and they have been synthesized and heavily used in the therapy of frequent diseases. However, the price people paid is side effects, and when you look at the most important side effect, which is the number of hospital admissions related to drug toxicity, it's high. It's different about this. It's different in the studies. No matter where you look at, however, it's between 1% and 6% of the patients ending up in a hospital are poisoned by the doctor. They are poisoned by our drugs and by drug interactions. So that's always a serious problem when we start to treat the patient, if the patient tolerates the medication, and we are always in a run to get therapies which work, but on the other hand, they don't poison the patient and don't make the patient even worse. Because nowadays the patient usually asks what I will get from this, what kind of side effects I will get from a medication, rather than what kind of benefit I will get from a medication. So this chemical revolution led to the synthesis of a number of broad spectrum anti-inflammatory drugs and also immunosuppressive drugs. You think of azathioprine, you look at cyclosporin A, and you can of course look at methotrexate, which is the mainstay of therapy till now, and it has been introduced as a cancer drug, and it's still used as a cancer drug to treat leukemia. Since the 40s and since the 60s, it has been, I have to say, used widely in treatment of rheumatoid arthritis. And the main change, I think, what we, at least in Europe, have faced during the last 20 years, that we now dose it more appropriately. Because when I started rheumatology in the early 90s, methotrexate was dosed with 5 or 10 mg per week, and now we use 20 mg to 25 mg per week. And I think it's much more appropriate as a dose, and this also contributed to the fact that many more patients are now in a low disease activity, not because we have much more drugs, but we use the drugs which are a long time already on the market in a more appropriate way, in a more appropriate dose. So let's go to biological therapy. So biological therapy was the answer of the problem of side effects of drugs, of chemical drugs, and it was facilitated by the introduction of molecular biology. When you look back, you can think the first biological therapy was an experiment Dr. Edward Jenner did, and what he did is basically he took a boy, and there was times where smallpox was endemic, and he took a boy, James Phipps, who was a 10-year-old guy, and he selected him because he was I don't know why he selected him, but because he didn't say no probably. He inoculated him with the cowpox, and the cowpox was a harmless pox virus, which does not make major disease in humans. However, what he thought is, and he observed people who had cowpox or had contact with cowpox before never get the smallpox. And what he did the experiment, he inoculated it with cowpox, and this boy was then inoculated with smallpox, and he never developed smallpox. So he was perfectly protected from smallpox, and since the cow is the vacca, it was called vaccination. So vaccination is, if you want, the first biological therapy, and we still use it. Meanwhile, smallpox is eradicated, and we don't have to do experiments with small boys anymore. So the real biological therapy was facilitated by the development of monoclonal antibodies, and In fact, the first monoclonal antibody, or the first description of the technology to produce monoclonal antibody, goes back to the 70s by Köhler and Milstein, and this has then been affected very strongly treatment. And the first approved monoclonal antibody was OKT3, which was a murine antibody against T cells, against the CD3, and it was used in transplant rejection, to prevent transplant rejection and to treat transplant rejection, because it wipes out all the T cells. So as you know, the T cells are important for transplant rejection. That was a breakthrough in therapy. It was a rescue in therapy of refractory transplant rejection in patients with kidney transplants. However, the antibody was basically a dinosaur, because it was a murine antibody, and you got a lot of side effects by the murine antibody, because you get antibodies against the antibodies, you got immune reaction, and sometimes severe immune reactions. So this was the introduction of the antibody therapy, and of course then a lot of antibodies have been developed, not only for treatment of rheumatoid arthritis, but also for cancers and skin diseases. And they have been developed in as humanized antibodies and fully human antibody, and are now much more tolerable. So if you want, the biological therapy in rheumatoid arthritis is a very recent development, and it was facilitated by molecular technology, and it was driven by the fact that the idea that you basically, with an antibody, you target only one molecule. And if it's the right molecule, you're very specific and very clean, and you can basically treat then the disease very well. It's however also important to find the right molecule, and many of these biological therapy failed. So only a few antibodies made it, or concepts made it to the clinics. When you look at the many cytokines, it's only TNF and IL-6 which showed efficacy in the treatment of rheumatoid arthritis, and many others failed, like interferon, IL-1 and IL-10 did not show a major efficacy in rheumatoid arthritis, and several others are still questionable. They may have a small effect, but they may not revolutionize the therapy anymore. However, what we learned is also that there is, it's to target one single cytokine like TNF or IL-6 is sufficient to affect a complex inflammatory process like rheumatoid arthritis, which is surprising. When you look at the first picture and saw that complex inflammatory tissue which harbors a lot of immune cells and a lot of mesenchymal cells, it's hard to believe that a single intervention like targeting one cytokine is sufficient to treat the disease very effectively. So there are master pillars, if you want, for an inflammatory process, which when you treat them, the whole inflammatory tissue falls down, but there are many of the cytokines which have only a minor role, and when you basically take it out, not much is happening to the disease. So TNF blockade has been very instrumental to treat different inflammatory diseases. It has also revised our concept in the understanding of inflammatory diseases and grouping diseases. So for instance, when you look at TNF-related diseases, you can find uveitis, you can find Crohn's disease, you can find ankylosing spondylitis and rheumatoid arthritis. However, there are others which are not TNF-dependent, gout and other diseases which are linked to the inflammasome, like Still's disease, are not very TNF-sensitive. So they are more IL-1-driven diseases. And even with the group of TNF-driven diseases, there are substantial differences. Imagine, for instance, that rheumatoid is very IL-6 dependent, and ankylosing spondylitis is not at all IL-6 dependent. It's completely failing so tocilizumab is completely failing in ankylosing spondylitis. So future therapy, anti-cytokine therapy, will also allow to dissect these group of TNF-related diseases more, especially the SPA group from the rheumatoid arthritis group, probably also skin disease from SPA. Imagine that skin disease is very sensitive to IL-17 inhibition, whereas arthritis doesn't look like to be very sensitive to IL-17 inhibitors. why are TNF blockers and probably also other of cytokine blockers very well appreciated? So they are appreciated, of course, because they work. And many patients which fail on methotrexate face a response to TNF blockade and are happy because they have less swollen joints and less tender joints. However, there is something else, and people like you treating patients sometimes observe that patients receive a TNF blocking agent and the day after they say, I feel much better. And they still have swollen joints. So this is very interesting. And in fact, it's not just we believe that, it's obviously also true when you look at this slide. This is a patient with rheumatoid arthritis who received a so-called functional MRI, which shows areas of increased blood flow in the brain, and increased blood flow in the brain is linked to neuronal activity. So you can show where the brain is active, where you see the red color, the brain is active. And when you infuse infliximab 1 day after, you can see that this activity is going down, and after 42 days it's completely gone, or almost completely gone. So that means that your TNF blockade affects the brain very fastly. After 1 day you have a response, and many of your outcome measures, patient global disease activity, pain, swelling sometimes, or not swelling but tenderness, is related to perception of disease in the brain. So when you affect the perception of disease in the brain, the patient will feel better and will tell you, doctor, you did a good job and my drugs work. Look at this, it's decreasing after 1 day. Your brain activity decreases with patients treated with infliximab, and when you look at the clinical responses after 1 day, you can see that the swollen joint count is the same after 1 day, the tender joint count is not changed, and also the DAS28 is not changed. So what you do 1 day doesn't change your inflammation in your joints, but it changes the perception of the disease in the brain, and that is probably why patients love such drugs, and they because they feel better before they actually get better. Look at the C-reactive protein. After 1 day, it's the same. IL-6, which is the key inflammatory driver of C-reactive protein in the serum of these patients, after 1 day, after TNF blocker is not changed. Of course, later it changes, but the brain is, if you want, the fastest measure of response in patient with rheumatoid arthritis. I will skip this slide. So what is very exciting, and when you think about this, you may think, well, maybe a patient responds to TNF blockade when his perception of the disease in the brain is high. And this is a very challenging concept, because none of the clinical, none of the serum markers, none of the genetic tests has yet predicted a response to TNF blockade. So you cannot basically predict the response by the gestalt of the disease. You have to, there is something else going on. And it's very exciting when you look at this, and we recently treated patients with TNF blockade and look at those patients who responded and those patients who not responded. And when you look at the responders to TNF blockade, they have a very high brain activity. So that means that they perceive the disease very strongly, whereas the non-responders don't perceive the disease very strongly. And then you see also that the brain activity rapidly decreases. That's a treatment with certolizumab, a subcutaneous TNF blocker, and these are clearly differentiating responders and non-responders. So what these few slides tell you, that a lot of the perception of the drug therapy is going on in the brain, and especially in a disease where you have not a clear-cut outcome measure like the creatinine level or the blood glucose level like in chronic kidney disease or diabetes, but you rely on how the patient feels and how the pain of the patient is and whatsoever. These things become very important. So the question is, do we need more treatments? Because sometimes people say, well, you have so many treatments in rheumatoid arthritis, it's not anymore an interesting disease and you can just stop to develop new drugs because you're anyway very, very good. But that's not really true, and that's just the perception. It's like the perception Europe is a rich continent, and it's also not true. Yes, low remission rates. When you look at the remission rates of, which is based on Euler remission of Euler remission of a DAS-28 of less than 2.6 after 12 months, you can see that that the remission rates are not 100%. They are less than 50%, and even when you start with a high baseline disease activity, your chance to get remission is even very low. So it's with the current treatment, real life experience, remission is still the case in a minority of patients. And this is consistent in many different epidemiological investigations in Europe. Here, a Swedish register, and Sweden is definitely a quite wealthy nation. And what you see here is that those reaching a DAS of less than 2.4 after 12 months are still only 20%. And those with low disease activity included, so 40%. So 60% of the patients are still in a condition where they are not adequately treated. And even when patient lower the threshold for remission, less and less patient will reach the goal of remission of the disease. So at the beginning, we should probably aim to get more people in low disease activity and remission rather than to be more strict with remission because it's not realistic. And the third argument that we need more drugs is that we have high discontinuation rate. Look at this slide. With all the three major TNF blockers used in worldwide, I think it's in Europe, but I think it's quite representative for other non-European countries. The discontinuation rates are up to 50% or about 50%. So that means that drug therapy is either not very well tolerated or the efficacy of the drug therapy is not so well that the patient stays on the medication for a long time. So how can we improve that, and what will be the next step in the treatment of rheumatoid arthritis? The next step is, of course, there will be probably other biologics coming, but what is a thrilling opportunity is to treat like a biological agent, very, very specific, but use an oral therapy. Why? Because an oral therapy will probably not cost, and I think it's about 14,000 euro in Mexico to treat one patient a year with a TNF blocker, and it's 25,000 euro in Germany to treat a patient 1 year with a TNF blocker. So it's a big challenge for health economy. And if you can target inflammation with a pill, which is very specific and very specifically interfering with the inflammatory process, you might be very good and might be a very interesting future concept. So is this feasible? Yes, it is feasible because we have this already. We have it with glucocorticoids because glucocorticoids are extremely specific for the glucocorticoid receptor. So they engage the glucocorticoid receptor, not 100 receptors, only one. And they do the job by engaging the glucocorticoid receptor and turning down inflammation. So if you want, it's a smart, it's a specific, and it's a selective small molecule drug therapy when you use glucocorticoids. But the problem is it's not very well tolerated in the long run and in doses which we would need to basically treat inflammation very well. So another approach, which is now it's a trendy approach and it might be very successful, is to treat the sensory system of the cell. So the sensory system of the cell is very important because when you live in your office and in a black box with no telephone, with no secretary, no patient will find you. And this is not very good because you will earn your money by seeing patients, and that is why you are a doctor and why you are there and sitting in your office. So you need a good communication with the patient, with the other doctors. You need to be trained. You sit here, you're going out. And that is, the cell has to do the same. So the DNA inside, when it sits in a black box, it would be for nothing. So the DNA has to have a telephone or a secretary. And this is the sensory system. So somehow the cell has to communicate when there is some problem outside. For instance, there is a cytokine outside and knocking to the door. And when the cytokine binds to the receptor, it knocks to the door, it has to be communicated to the DNA. And the DNA then triggers the cellular response. It shuts on the gene, and the cell either dies or proliferates or makes cytokines and whatever, or moves around, whatever. So this is extremely important. And when you target basically this cellular system, this basically post office of the cell, you may inhibit the action of cytokines to the cell. And that's the concept how modern targeted therapy works. So these communication systems are the kinases, and kinases are basically proteins which activate other proteins. They just put a phosphate, and that's why the name kinase, on another molecule. And there are about 400 kinases. So you work basically by having about 400 kinases which make your body work and which communicate what growth factors are doing and cytokines are doing to your body. And the most important cytokines in inflammation are about 4 different major pathways. One is the MAP kinase pathway. It's a very complex pathway which is signaling TNF and IL-1, and targeting of which has so far not been very successful, but the trials are still ongoing. Then there is the SYK kinase pathway, which is I will present to you, which is extremely important for all the signaling of FC receptors, of the B cell receptor and the T cell receptor. Then there is a very central pathway, which is NF-kappa B, which is a central pathway of inflammation, which triggers the response of many inflammatory cytokines, but is a very fundamental pathway and is probably very toxic to target this pathway because it is necessary for a wide variety of biological function. And then there's the JAK pathway, which is also triggering a lot of different cytokine responses, and I will present you some ideas about this pathway. So which kinases should you target? These are called the tyrosine kinases, and the tyrosine kinases are these kinases which are now most interesting for chemists to develop drug against the kinases. One of the tyrosine kinases are 2 groups. One are receptor tyrosine kinases, and one are the non-receptor tyrosine kinases. So the most famous receptor tyrosine kinase is the insulin receptor. So the insulin receptor, and everybody knows, and this is a very crucial metabolic trigger point, and this is a tyrosine kinase. And there are other kinases which are not receptors. These are the non-receptor tyrosine kinases. They swim in the cytoplasm and basically are responsible for triggering responses of cytokines to cells. And these are the ones which are interesting to treat in diseases like rheumatoid arthritis. So there are already tyrosine kinase inhibitors which are used for the treatment of patients. One of it is imatinib. And imatinib is a tyrosine kinase inhibitor which is quite specific. It's not completely specific for one single kinase. So you can see here a hit, and here 2 hits. So it targets at least 4 different kinases. And imatinib was a revolution, if you want, in the treatment of chronic myeloid leukemia, and also a revolution in gastrointestinal stromal tumors, where patients survived the disease, and usually the patient died from these diseases, and imatinib was a rescue for them. And there are other drugs which are doing the same, like nilotinib and others, which are treating tyrosine kinases like EGF receptor or the PDGF receptor, or c-KIT and c-FIMS, which are important in cancer treatment. So we don't yet know if a tyrosine kinase inhibitor should be extremely specific for one kinase or should be a little bit dirty, because it could well be that the more specific a kinase inhibitor is, the less efficacious it is. But the other problem is when it's not very specific, the likelihood that you get side effects from your inhibitor is higher. So it's always a balance, because it's also a chemical compound, how specific you are and how much toxicity you can get with your drug. So look at the different tyrosine kinase inhibitors, and you see that there is a huge difference in the specificity. This is imatinib. It's a quite specific inhibitor, and in general, this is what you wish, because you don't wish to target tens, dozens, or hundreds of kinases, and they're very unspecific tyrosine kinases like staurosporin, which basically target all tyrosine kinases, and these are very toxic compounds. So when you look at tofacitinib, and it was formerly termed tasocitinib, it's a JAK inhibitor. It's quite specific. You see not so many red dots, only very few, and these are the JAK kinases. So this inhibitor is probably very much resembling what imatinib is doing with other tyrosine kinases. So it's a quite specific inhibitor, and it is not very dirty. So the key tyrosine kinase targets for rheumatoid arthritis are the JAK kinase pathway and the SYK kinase pathway. You can see them here. This is the JAK kinase tree, and here is the SYK kinase. So very small pieces, if you want, of the whole kinome. So it's in fact a very selective intervention. Like with you, when you treat with a TNF blocker, only one cytokine of many different cytokines. So a few words to SYK. So SYK is, the name comes from spleen tyrosine kinase because it has been originally described in the spleen. And this kinase is predominantly expressed in B cells, but it's also found in myeloid cells and NK cells. And it is very important for signaling of the B cell receptor and the FC receptor. So when your immunoglobulin binds to a cell, to FC receptor, it's using SYK to activate the cell. And when a T cell is activated by an antigen, it uses SYK to get activated. So if you don't have SYK in a B or a T cell, it does not work appropriately. So SYK inhibitors are in clinical development. One of them is fostamatinib, which showed very good effects in the treatment of rheumatoid arthritis. And the key issue is that the potential of SYK inhibition is to target B cells. And in fact, when you knock out SYK from an animal, you don't have B cells. And the reason for is that B cell development is dependent on the B cell receptor. And SYK is downstream of the B cell receptor. And when you don't have SYK, a B cell cannot get activated, but also that does not develop appropriately. So you lack basically B cells when you have no SYK. So the SYK inhibition would basically target very well B cell activation. And as you know, B cell targeted therapy is something which is interesting in rheumatoid arthritis because CD20 therapy, rituximab, works very well in patients with rheumatoid arthritis. And SYK is also instrumental for the activation of macrophages, for the phagocytosis function of macrophages, and it's also important for mast cells, for histamine and cytokine release of mast cells. And you know, mast cells are releasing a lot of tumor necrosis factor. Mast cells are in the synovial membrane of rheumatoid arthritis, and there is no therapy yet which treats mast cells, and that might be very important when you inhibit SYK. And there are other cells which are SYK-dependent, osteoclasts, for instance, which resorb the bone, and platelets, which are always important when there is inflammation. You get platelet activation, share a common concept. They need SYK to get activated, and that's why the inhibition of SYK probably affects a variety of cellular responses in inflammation. It's B cell activation, it's mast cell activation, it's the resorption of bone by the osteoclast, and it's also the function of the macrophage during the phagocytosis. So it will be an interesting to see how these how these SYK inhibitors will work in the future. They work in animal models of arthritis. You can see here where they inhibit inflammation, and there is a phase 2 study already finished. You can read it up in the New England Journal of Medicine, showing that SYK has a similar efficacy like a TNF blocker in treating patients with rheumatoid arthritis. Of course, we have not much safety data at the moment, and we have to wait if such therapies are also safe. The other approach to target intracellular signaling is the targeting the Janus kinases. And Janus kinases are named like the Roman god Janus, which symbolizes the beginning and the end, and has two phases. And the name Janus kinases, shortly called JAK, comes from the fact that these kinases basically have two parts. One part is doing the job, it's putting the phosphate to another protein, and the other part is regulating it. So these two parts make this, so the two-phased kinase. So how does it work? So it works very simple. When a cytokine is binding to the receptor, JAK is attracted, so it binds to the receptor, to the cytoplasmic tail of the receptor. It then phosphorylates the cytoplasmic tail, and it activates the receptor. And when it activates the receptor, other proteins come by, like STAT, and then they activate the cell and make the signal. So that's a fundamental concept how JAK kinases work, and many cytokines work to cells. So when there is not this activation by JAK kinase, a cytokine, it can be there, can bind to the receptor, but nothing happens. So why do we think JAK kinases are important in the treatment of rheumatoid arthritis? Because there is, in both humans and in mice, there is a phenotype on the immune system. So when you knock out JAK3, either there is a genetic mutation in humans, which leads to SCID, that's the severe combined immunodeficiency, or in the mouse, where you can do it by genetic alteration, you end up also in a severe combined immunodeficiency. So that tells you that JAK, and especially JAK3, is very important for the immune system. You don't want to knock it out, because you don't knock out TNF from a human when you treat with a TNF blocker, but you can blunt the activity of JAK, and that might intervene with the immune system and stop inflammatory disease. So these are the cytokines which bind, which work through JAK, and I'm sorry for the Greek here, it's not intended. And dependent which, there are three JAK kinases, and JAK 1, 2, and 3. The inhibitors usually inhibit all of them, yeah? And dependent which, the cell has different pairs of receptor, either JAK1, JAK3, or JAK1, JAK1, or JAK2, JAK2. These are important for signaling for different cytokines and growth factors. You see, many of these cytokines are important in inflammation. Here you can see IL-6, for instance, and you see also that many growth factors signal through JAK, especially JAK2. One famous part is APO, erythropoietin, uses JAK2 to drive erythrocyte production. So tofacitinib is a JAK inhibitor, and it affects all three JAK kinases. There is some preference for JAK3, which is intended because JAK3 is the one important for the immune system. However, it also inhibits JAK2, and therefore you can sometimes explain the potential side effects of JAK inhibitors in the clinical use in the treatment of rheumatoid arthritis. So JAK is working in the animal model. When you inhibit JAK in a classical model of arthritis, which is the collagen-induced arthritis, you can see what a drug should do. It inhibits inflammation, so it has less swelling, which you see here, and there is less joint damage. So there's less bone damage, less cartilage damage. So the drug is doing what it should do in humans. And in fact, the clinical trials for this drug are very promising. So you can see here is the ACR20 responses of different doses of JAK inhibitors, and you can say basically you have responses, ACR20 responses about 70%. So that's usually the bar you get and you want to get because that's what you get with TNF blocking agent. And I think it's quite thrilling and surprising and interesting that with a small molecule like JAK inhibitors and also SYK inhibitors, you can reach such ambitious goal to reach 70% responses in patient. And also the response rate, the more stringent response rate of ACR 70 are up to 30%. So that reflects also very much a cytokine blocking strategy. So we will have to, of course, wait on the large phase 3 trials which are going on with these drugs to finally conclude whether they are really as good as a cytokine blocking agent, but at least it's an interesting development, and we will see how it will work in the future. So in summary, I have shown you that intracellular signaling pathways, especially the SYK kinase pathways and the JAK kinase pathway, are the key targets for future anti-rheumatic therapy. And after the chemical revolution, which in the 20th century, which brought us methotrexate, which is still the mainstay of therapy in rheumatoid arthritis, and the biological revolution at the end of the 20th century, which brought us antibodies like anti-TNF, anti-IL-6, anti-CD20, CTLA-4 Ig. There will be a phase, probably kind of a renaissance of small molecules, especially small molecule inhibitors which target the tyrosine kinases in the body, which obviously show a very strong anti-inflammatory activity in patients with rheumatoid arthritis. And I thank you for your attention.
Muchas gracias, doctor Schett. Tenemos tiempo para preguntas. Supongo que tendremos muchas en el auditorio y hay micrófonos circulando. Por favor, levanten la mano para poder acercarles el micrófono.
Thank you, George, for your talk, for your lectures. I have a question for you. The first is, the JAK or SYK inhibitors is a biological drugs, or both are not biological drugs? And the second question is, what do you think the role of this molecular in the treatment on rheumatoid arthritis? Are DMARDs, are not DMARDs? Is a different kind of groups you are going to use in the first line, the second line? What do you think about this question?
So to your first question, they are small molecules. You can swallow them. They are just pills. This is definitely a non-biological drug, so it's a chemical drug in a way. And to your second question, I think it's a complex question, because at the end, what could be a scenario? So if the drug is working very well, yeah, it's behaving like a TNF blocker, and if the drug is safe, yeah, and we don't know that because we have to treat 10,000s of patients, yeah, to know this finally. Then it could have a strong place in the therapy, especially probably after methotrexate, because still. That depends on the price also. When the drug is €1,000 and methotrexate is €10, you have to justify why you use tofacitinib rather than methotrexate. So these are the issues. You know, first, is it really that efficacious? Number one. Number two, is it that safe? And number three is what's the price? And these are the things which then determine where it is in the place of therapy of rheumatoid arthritis. So it could be before biological agents, because it will be probably cheaper than biological agents, and if it works very well, it could be before a TNF blocker. That would make sense, because I mean, when you go into the market and you end up after all the biological agents, your market is probably small, you know. So the idea is probably to go, and I'm not a company person, to go for earlier intervention. But that, of course, in a wide use of a drug, it needs to be safe, efficacious, and economic. And these things we don't know finally, because it's not yet approved.
Doctor Martínez.
¿En inglés entonces? Okay. thank you for your lecture. How would you compare tofacitinib, for instance, with another small molecule like leflunomide?
Well, there's no head-to-head comparison, of course. So when you look at methotrexate and leflunomide, which behave very similar in efficacy, they are not that bad, especially when a patient is naive to methotrexate. Their responses are very good. So there is not a fundamental difference in the response in biological naive or methotrexate naive patients between a TNF blocker and the methotrexate. So in fact, tofacitinib is probably better tolerable because and also clinical studies are bigger now to get approved than in leflunomide, which was more than 10 years ago, and that's why it's more rigorously tested before it comes to the market, and that might be an advantage. And also the mode of action is much better known with tofacitinib than with leflunomide, because nobody knows how leflunomide works. It's probably a broad spectrum, it's like methotrexate, you know, it's a broad spectrum immunomodulator. Yeah. And at least my personal experience that the patient like to know how a drug works, you know, and the patients are always a little bit concerned when they don't know. When you explain how methotrexate works and the patient asks you, how does methotrexate work, doctor? And you say, I don't know, but it works. Nobody's happy. I mean, this doesn't make people very comfortable. They say the doctor doesn't know it. You know, why does the doctor doesn't know why the drug works? I mean, that's always a difficulty. And because it's based on empiric testing, yeah, that's the problem. Nobody will ever elucidate how methotrexate, there's not one mechanism how it works. And that makes sometimes patient a little bit uncomfortable. Yeah.
Okay. Two quick questions in relation with this. So far, what's the experience using tofacitinib alone as monotherapy or in combination with methotrexate? That's question number one. And the second, so far, what can you tell us in terms of the safety profile, adverse events with tofacitinib?
Well, you know that the safety profile from the is on the liver function test is very much methotrexate dependent in tofacitinib studies. So tofacitinib has probably a lower, it's probably a lower liver toxicity profile than methotrexate, and that's and I think there is definitely the room for the monotherapy with tofacitinib. There is no real issue to combine it per se with methotrexate because it works as a monotherapy very well. Yeah.
Dr. Jara.
Thank you, Professor, for your conference. I think that you include all factors that genesis of rheumatoid arthritis, but I think there are other factors. For instance, hormones, neurotransmitters, the neuroendocrine system, and the relationship with central nervous system. And it's possible that participate in the pathogenesis of rheumatoid arthritis. Different reports suggest that TNF alpha treatment, including improve the immune neuroendocrine system altered in active rheumatoid arthritis. Recent studies mentioned that methotrexate plus prednisone is a new gold standard. This is in relation with emphasize the use of prednisone in comparison with TNF alpha blockers. What's your opinion about this? Is the new studies that
so is the question more related to glucocorticoids?
Glucocorticoids, okay. Yes.
Prednisone
versus TNF alpha glucocorticoids maintained a long time patients, low doses.
Well, I think glucocorticoids have only a role in the induction of therapy. So we use glucocorticoids when we have a patient who is ACPA positive, has 10 swollen joints, and starts with the treatment. We usually give glucocorticoids at the beginning plus methotrexate to get fast relief of signs and symptoms, fast control of the disease, because methotrexate takes 6 or 8 weeks till it works. But then we basically taper the glucocorticoids and we completely stop them. So the glucocorticoids are wonderful, but wonderful in the short run. And also when you treat a flare, you can use glucocorticoids very well. The philosophy is a little bit different in different countries. Some of the countries prefer to have patients, of the rheumatologists, to have patients on 5 milligram of prednisolone for the long run. Some of them just stop it. I think that's a little bit based on taste, what people do. I personally always try to stop the glucocorticoids, and when the patient is happy, I am also happy when there is no glucocorticoid therapy there. However, I mean, there might be a role if, for instance, you cannot control completely the disease with methotrexate, and addition of a low-dose glucocorticoid therapy might be very helpful. Also, when or also an evening glucocorticoid might be sometimes helpful for morning stiffness, if this is a major problem. So these are the things where you, of course, can do it. Yeah, but I am very uncomfortable with more than 7.5 mg of glucocorticoids. I'm very uncomfortable. I really always try to get the people off such a treatment because it has a very high infection risk. It is a very strong risk factor for diabetes, and especially the patients sometimes are older and are prone to diabetes. So there are a lot of problems, I think, when you go over 7.5 mg per day in the long run.
Thank you. Alejandro?
There's a question from our colleagues in the internet. Dr. Leobardo Terán asks if there's any mention of tofacitinib in the new ACR EULAR recommendations in the management of rheumatoid arthritis.
Well, I don't think so, because it's not yet approved.
Exactly.
And so we always have to make recommendations on the drugs we have available, and of course when it will be available, there will be another place for doctors to write the next paper on recommendations.
Okay. There's another question from the internet. Dr. Hernandez in Tlaxcala asks if these inhibitors as biologics required a DMARD to decrease the production of neutralizing antibodies.
So I think the question refers to biologics plus methotrexate to basically decrease the number of neutralizing antibodies. Yes, that's a fair question, and that's what we actually do. By far, most of the therapies, biological therapies, are on top of methotrexate. So the standard regimen we are doing is when patients fail on methotrexate, we add the biological agent. Mostly it's a TNF blocker. That might change a little bit based on the new data that the tocilizumab therapy is also very efficacious as a monotherapy. Yeah, and also there are abatacept might be also very efficacious as a monotherapy. So if there is high efficacy of a monotherapy, it's also consistent efficacy on the long run, there is probably no sign for neutralizing antibody. Yeah. In general, I think we do the combination with a small molecule, mostly methotrexate and biological agents at the moment, and that might stay with TNF blockade because there is an added effect of methotrexate and TNF blockade. I don't see that this will change now in the next time, but maybe it change a little bit with other biological regimens like with tocilizumab especially.
And one question from me. How fast are these medications working compared to biologics?
You mean tofacitinib?
Yes.
Relatively fast. So the onset of action is after a few weeks already. So this is also quite surprising. So they might be faster than methotrexate.
Okay.
That's probably based on the fact that they act as cytokine inhibitors. So what tofacitinib is doing is a broad spectrum cytokine inhibitor. And cytokines are probably linked to this, it's necessary to, cytokine inhibition at least is known to have a fast effect in rheumatoid. And tofa is basically mimicking cytokine inhibition as a small molecule.
Okay, thank you.
¿Alguna otra pregunta? Doctor Silveira. Viene el micrófono.
Thank you, Professor Schett, for your talk again. What about the combination of these small molecules, the kinase inhibitors, with a biological? That would be a little bit crazy for you?
No, not at all. I don't think so. I mean, that will probably come. In fact, what you say, I always thought, why do we not regard tofacitinib as a methotrexate, a better methotrexate, and a good combination part to a biologic? But there are no data yet, but I think in general that would make sense. I mean, when it's safe and it's efficacious, why not? And also there could be an added action between tofacitinib and TNF blockade, for instance, because TNF is not working through JAK, so there could be a synergy. Yeah. The only thing is that it has to be safe. You know, when you add infectious risk, when the infectious risk is going up, then you can't do that. So in general, I think it will be primarily used as a monotherapy, and dependent on the programs, what they will do, companies will. Strategies of company. I think it would be good to stimulate company to make studies as at least small studies in combination with a biological agent. It's then also dependent on the price. You know, when the price is like a rank ligand antibody, which is costs of $1,000 or euro per year, you can think of combining it with a biological agent. But when the price is half of a TNF blocker, it's not feasible. I think it's the price issue. I think is then also some point which need to be considered. But I like the idea, and I think it makes, from a biological perspective, it makes a lot of sense. Also with SYK inhibition. Yeah.
Otra pregunta. I have a question. We have many patients who have, let's say, a standard RA, and they respond adequately to standard doses of methotrexate, and we don't have a problem with them. But we have other patients who do not respond to 25 milligrams per week to methotrexate. We start using combinations. We start using TNF, anti-TNF, IL-6, or whatever, and they do not respond. Is there any way to know in advance, in a practical point of view, if we can predict which is the best treatment for this particular difficult patient? Is it coming soon?
No.
Because we always are using biomarkers and genetic markers.
But you cannot predict. No, there is no real prediction. I mean, that is the difficulty. It's a try and error therapy, what we do. And the only so concept is that the antibody positive patients respond better to rituximab, but even this is not consistent. So the answer is simply no. We will use the best treatment we consider best, which is working and it's safe and it's cheap at the beginning, and then go to more exotic regimens when the patient does not respond. That's what we will face in the future, I think. Very likely. Yeah.
Thank you. Quisiera agradecer a través del Colegio Mexicano de Reumatología la presentación del Dr. Schett. Dr. Schett, please stay here. We have a diploma for you, and it says, on behalf of the Mexican College of Rheumatology, we want to thank you for your participations as guest professor on both lectures, one at the National Rehabilitation Institute and the other one here in our monthly session. We know that they are great contributions to the academic program of our organization. The president, the vice president, the secretary, and the treasurer sign these diplomas, and our society has also a present for you. I hope it's not that heavy. Thank you so much.
Yeah, thank you very much. So I want to thank the organizers and for inviting me. It's my first time in Mexico, and I really enjoyed it. I have seen a lot of very engaged people here, wonderful hospital, and I think a very nice group here. And I also had a lot of Mexican food today, so I will sleep well, I think.
And also their side.